escape button. I'm not really competent here.
Good morning. Thank you very much for that really kind and generous introduction. It's sometimes, not sometimes, but most of the time, it's a really too kind of an introduction. I'm not sure, but I will take whatever I can get, and I'm sure it's really quite an honor to be here, celebrating the almost the coming fifth anniversary of the passage of the House Bill 81 in Utah, which is a trailblazing legislation, that really has been pretty much instrumental in this type of legislations that's taken up by many other states. And right now there are 9 states that have laws on their books, and several other states are considering. This is all driven by parents and families and advocacy groups, and especially here in Utah with Albert Park and Jim Bale and Carl White and the family itself of Sarah Dutre, mom, and Representative Menlo. So this is really exciting. They're setting an example for how to really get things accomplished outside of in the clinical arena. Sometimes, we as a professional organizations or societies, we tend to really maybe parse things too much, which is really appropriate, but also forget the families and the children who are suffering and need some help and need the awareness. So I'm really, really excited to be here. This is my disclosure. I have a research grant from Meridian Biosciences to look at saliva rapid testing, and then I'm also a paid consultant to CMV Vaccine Advisory Board for GSK and Merck. The only unlabeled or off-label use is of the ganciclovir or valganciclovir in the treatment of congenital CMV infection. I just wanted before, because usually even with my gray hair, I always have more slides than the time permits. So I want to acknowledge the people that really helped me along. And I had the tremendous opportunity to work with a great group of friends, colleagues, mentors, and collaborators, not just in the at UAB, but around the U.S. and in the world. So this has been really a great journey, and I'm still learning. And I tell people that this is maybe I was so naive 25 years ago, more than 25 years when I started out, or maybe I'm a little bit wiser now, because what I tell people now is, and I certainly know much less than what I thought I knew about congenital CMV 25 years ago. So there's still a lot of unanswered questions. And then hopefully we'll answer some of those questions with some of the ongoing studies. So Albert mentioned the CHIME study, which is a multi-center newborn screening study, which is a huge undertaking, with a large number of people involved at 7 different sites. The credit is all to the people who worked hard, and also the families who participated in the study. And then, of course, the NIDCD to supporting it. Okay, the outline of my presentation, I'm just going to briefly talk about disease burden. I'm sure this is a repetition or maybe preaching to the choir, but just to emphasize why CMV, congenital CMV, is a huge problem, not just in the U.S. but worldwide. Briefly about treatment interventions. Mostly in the context of how we can identify and how we can think about strategies for identifying most babies with congenital CMV infection early in life. And then, if time permits, I'll talk about some of the data as well as understand what we understand now of the pathogenesis and mechanisms of CMV-associated hearing loss, and outline some knowledge gaps. So this is just a brief background. I'm sure most of you know. If you don't know now, you probably learned in medical school, or somewhere along the line, CMV is a large double-stranded DNA virus that it belongs to the herpes virus family. Just like any other herpes virus family, it's a lifelong persistent infection. One of the hallmarks of congenital CMV infection is the presence of these owl-eye appearing cells well, I'm technologically challenged here, so I don't really know. I know they told me how to get this to work, the mouse, but anyway, one of the big problems with congenital cytomegalovirus is it's a highly species-specific virus. So the human CMV only grows in human cells, and almost every animal species that we know of has a CMV of its own. So it's very hard to really study human CMV in a mouse model. Our guinea pig model, you have to use guinea pig virus, you have to use mouse CMV virus. So that's been one of the major impediments in terms of understanding the mechanisms of disease and pathogenesis of CMV. About congenital CMV infection, it's a common congenital infection. Anywhere from 5 to 10 babies per 1,000 live-born babies are infected with CMV every year in the U.S. It's a leading cause of, I would say, non-genetic leading cause of sensorineural hearing loss and brain disease in children worldwide. Not just in the U.S., but everywhere, even in populations where almost 99% of women of childbearing age are CMV seropositive, congenital CMV still continues to be a problem there. So only about 10 to 15% of infected infants have some sort of a clinical findings that you can identify. But even then, even among those, I think a lot of us think it's probably maybe about half of them are clinically identified, and those with subtle findings or nonspecific findings are usually not picked up. And of those who are symptomatic, about half of them have some sort of sequelae that includes hearing loss or cognitive-related motor delays, seizures, and vision abnormalities with defects. So the most babies with congenital CMV infection have no symptoms at all, no clinical findings that you can identify in the nursery. But about 10 to 15% of these children go on to have sequelae, most common one being hearing loss. So just to put this in perspective in terms of the numbers, these are the infection rates in the US, Canada, Western Europe, in Australia and Japan. It's probably close to 5 per 1,000 live births. And in most of the other parts of the world, Latin America, Africa, well, with the data that we have, and Asian countries, the rates are between 10 and 20 per 1,000, which is counterintuitive, as you think about seroprevalence, as you compare it and contrast it with congenital rubella. If we have high seroprevalence, you don't see congenital rubella. So whereas congenital CMV continues to be an issue or problem, or actually much bigger issue in societies or populations where most people are CMV seropositive to begin with. Just in terms of the numbers, the estimated numbers of congenital CMV infection in the U.S., the babies they're born with it are between 20 to 30,000 a year. You can see in Brazil, based on the birth rates, there are about 35,000. I know, there are 270 million babies are born in India each year. So you can imagine the number of babies that have congenital CMV infection there. Nigeria, it's anywhere between 65 to 130,000 babies are born. So these are staggering numbers. Of the 4.1 million live births in the U.S., we have about between 3,500 to 5,600 babies who have some sort of a sequelae from congenital CMV infection in the U.S. So in terms of the public health importance of the prevalence of congenital CMV infection, you see congenital CMV infection is much more prevalent compared to any other things that we talk about here, Down syndrome, spina bifida, cystic fibrosis, or toxo. in terms of the disease morbidity, but neurologic morbidity from any of these conditions in the congenital CMV infection equals that caused by Down syndrome, or pretty close to, or even more than what's caused by fetal alcohol syndrome. So it's a pretty important and prevalent disease. I'll skip this for now. So unfortunately, even with all the numbers I quoted to you, this is the Sarah Dutrace data that was published. The Sarah Dutrace, the DAISY, that's the responsible, I guess, whose cause led to the passage of HB 81. Anyway, so you can see here, compared to the annual incidence here, the awareness about congenital CMV infection is pretty low. It's only about 5 or 6% of the population have ever heard of it. That's true. I mean, maybe not that low, but that's true. The surveys that were done, even with providers, pediatricians, OBGYN providers, that seems to be pretty low compared to things like, the one thing that's not on here is probably off the charts would be Zika, right? I don't know anybody here has seen a congenital Zika syndrome patient, or maybe few, but I have not, So this is an example of, this is a piece in New York Times by Catherine St. Louis, giving an example. This is a baby, Evelyn Stedman from Illinois, who has congenital CMV infection. Just explaining the CMV is a much greater, or far greater threat than Zika, but far less often discussed or people are aware of. So the overall prevalence of congenital CMV infection based on our time study is about 0.5% or 5 per thousand. So I mentioned that congenital CMV is also a huge issue in countries, resource-limited settings or developing countries where the seroprevalence is high. Sorry. Okay. I don't know how to get this mouse to work, but anyway, Albert, can you help me? Sorry. Okay, great. All right, thank you. So let me go back here, okay. So this is a review paper from Tatiana Lanzieri at CDC, published in 2014. We have subsequent data from our collaborations and other studies published. Is consistent. As you can see here, in this column here is the seroprevalence of the population, and these are the prevalence of congenital CMV infection. One common theme here is, we don't, the prevalence is actually at least twice or 3 times as much as it is in the U.S., pretty consistently across the board. There may be some studies that have shown prevalence closer to what we see in the U.S. So it's amazing that, even with all the pre-existing seroimmunity, congenital CMV infection still seems to be a big issue. This shows this is from Mike Cannon's the paper, plotted the seroprevalence in colors here in populations where seroprevalence is greater than 90%, and then this dots represent the prevalence of congenital CMV infection. Pretty much most of the populations with high seroprevalence, you have a higher rate of congenital CMV infection. This is the data. We have a lot of all these unshaded areas that we don't really have any published data. So just to summarize, about 5 to 10 babies per for 100, for 1,000 live births have congenital CMV infection. That's about 20 to 30 or 40,000 babies each year, and majority of them are asymptomatic, and a small number of symptomatic, and majority of symptomatic babies will have some sort of sequelae, but about 10 to 15% of those with asymptomatic infection also have sequelae. There's just an example. What we think about symptomatic infection is, find clinical findings we can categorize them as transient findings, but usually whether you do anything in terms of the treatment, they go away. Like petechial rash, purpura, ecchymosis, thrombocytopenia, enlarged liver and spleen, and conjugated hyperbilirubinemia, they usually resolve. And there may be a small number of babies with refractory thrombocytopenia that would need antiviral therapy. Anyway, but I think the one we worry about is the involvement of the CNS that would lead to permanent sequelae. These include microcephaly, hypertonia, poor seizures, chorioretinitis, and changes in the neuroimaging, which include most common intracranial calcifications, but also have a variety of other neuroimaging abnormalities that could be seen, and also sensorineural hearing loss. So, but most babies are not like the other baby I showed you. This is just like any other baby in the nursery, could have congenital CMV infection. But right now since we don't screen all babies, we don't test them. Majority of these babies are being missed. One of the difficulties, in terms of estimating exact contribution of congenital CMV infection to hearing loss is because we don't really have a good diagnosis. Either we don't identify all of these babies early enough, and then usually after 2 to 3 weeks of birth, a positive virologic test doesn't really confirm congenital CMV infection because the babies can acquire CMV natally or postnatally. So in terms of the interventions, I think one of the problems that have been cited as for universal newborn CMV screening is that we don't have any kind of intervention. I don't think that's true because, we do hearing screen. We screen all babies for the hearing, not because there is a simple treatment. Early identification and the early intervention, whether it's a drug, whether it's some sort of amplification, or some babies need cochlear implantation, that makes a huge difference for their long-term outcomes. So, and then antiviral therapy right now for congenital CMV has only been studied in symptomatic infants with symptomatic infection. The limitations of the data is the follow-up is not long enough to know exactly how they do or in the long term. However, there are 2 new treatment trials that are planned in babies with asymptomatic infection. One is actually Albert Park is getting a new study of a randomized trial of valganciclovir in babies who fail their hearing screens and then test positive for CMV. So hopefully that study will inform us whether treatment of babies who only have hearing loss as the sequelae or finding of congenital CMV infection, the antiviral therapy will be effective. And then David Kimberlin at UAB is beginning an open label study of treating all asymptomatic infants with asymptomatic congenital CMV infection with I think 4 months of valganciclovir. So that would also tell us now, hopefully in a few years, we have much more information and much better data to decide which of these babies. One of the huge problems we have in the field is, of the 85 or 90% of asymptomatic infants are 85 or 90% of congenital CMV infection, congenitally infected infants who are asymptomatic. About 10 to 15% develop sequelae. So we have absolutely no clue who those are, which are the predictor, whether we don't really know how to identify those babies who are at risk for hearing loss or other sequelae. So that's one thing that's being actively investigated right now. So I don't think I need to really emphasize this much more, because this is very well proven that early intervention works very well in terms of improving outcomes for children with hearing loss. This is from Carl White's NCHAM website. So undetected hearing loss, even mild, even unilateral, has serious negative consequences on speech, language, social, and academic development. And the dramatic benefits have been associated with the early intervention. early identification and intervention. So I think, I mean, this should be the main focus, the main reason why we would want to identify all babies with congenital CMV infection. Not necessarily I mean, it would be great, it would be awesome if we have a drug that we can treat. Well, it would be great if we can identify babies who are at risk, and then we have a drug who can, who would benefit from the pharmacologic agents. But even before we have a drug, and I think we should still, there are ways to improve outcomes. So this is the data from David Kimberlin's valganciclovir trial, 6 weeks versus 6 months of a babies with symptomatic congenital CMV infection. They followed the baby. So the primary endpoint was actually 6 months. As you can see, there's not a statistically significant difference in outcomes. This is hearing improved or no change in hearing at birth at 6 months of age. So there is a slight difference, but it's not statistically significant. Whereas at 12 months and 24 months, there seems to be much more, a little more of a benefit in terms of improving our stabilizing their hearing loss. So this is the data that's being used right now to make recommendations about treatment. This study also had a trend towards improved neurodevelopmental outcomes in the 6 months group compared to 6 weeks group. Although ganciclovir is a pretty toxic drug, one promising thing is in this study, at least the valganciclovir doesn't seem to be as toxic as is IV ganciclovir. They also saw some liver function abnormalities at 4 and 5 months of age at the very end of therapy. That's a little bit of a concern. We don't really know what it means right now. So the recommendations, I know there's a consensus group that got together in 2015, in terms of which, they talked about a lot of different issues. One of the topics of the discussion was treatment. So the only group that was recommended to have antiviral treatment right now is a moderate to severe symptomatic infection. So because that's the only data, there's the only population, there's some randomized control data providing benefit. So the next maybe 5 or 10 minutes, I want to talk about newborn screening for CMV. So how do we identify babies with congenital CMV infection? As I mentioned, a small number of babies are picked up in the nursery because of some sort of a clinical abnormality, what we call a symptomatic infection. But as I also mentioned, that a significant proportion of babies with symptomatic infection who have either mild symptoms or who have non-specific clinical abnormalities will not be picked up. So the majority of babies with asymptomatic infection are not going to be identified unless there is some sort of a screening program, which is either targeted screening or universal screening. I'll describe what targeted means. I think that's being done in a lot of places right now, at least some of the institutions. But this is just an example of what I look at it. So most babies with congenital CMV infection are what we think is below the surface. The only ones we see are the tip of the iceberg, who are symptomatic. So if we don't do any screening, if you're based on clinical findings, you would identify some of these babies. And if we do hearing screening, a certain number of these babies with congenital CMV infection and hearing loss would fail their hearing, so they will be picked up. But still, you have this big chunk, large proportion of babies under the surface that we don't see right now that are not going to be picked up unless you do some sort of screening. There's not some sort of screening, it would be universal screening. And also, even with the hearing screening, there's still some babies who pass their hearing screen will go on to have hearing loss, a delayed onset hearing loss that is not going to be picked up. Excuse me. So the targeted screening is a strategy what what people have been using, where we screen all babies who fail their hearing screens for CMV. Okay, so this, I mean, Albert talked about this HB 81, the Utah bill that started really. I mean, I think, well, I would actually give credit to Pablo Sanchez when he was in Dallas. He was actually doing this it was probably the only institution that has done it for a considerable period of time. And then this came along and the Utah initiative, and then that led to a lot of other states pass laws. This is the slide from National CMV Foundation website. As you can see, there are 9 states here that have laws in their books, and several other states are considering the laws, considering legislation. And then I think the Maine actually proposed universal CMV screening last year and did not pass, but they're reconsidering it again today, this year. So we'll see what happens. So this is all mostly advocacy groups, or the momentum is by parental groups and advocacy groups. And then I think I would say the only professional organizations that have been at the forefront, I would say, is the audiology community. You know, the pediatrics AAP is staunchly opposed to some of these legislations for a variety of reasons. Some of those are very legitimate and reasonable. So this is a summary of legislative mandates. You know, we have 9 states with the laws, education and screening mandated in 3 states, and education screening of pregnant women and providers. So the educate professionals, these are the states that have this mandate to educate public and professionals, and educate women of childbearing age, that's in Tennessee. Only Utah legislation is accompanied by ongoing funding. There's a small amount that's allocated in Idaho. That's a proposal that has not been passed. So, and then the 3 states are mandating or requiring newborns who fail their hearing screens to be tested for CMV. They include Connecticut, Iowa, and Utah. In Illinois, it mandates that the screening be offered. So there are a whole variety of other states that are considering similar legislations now. So whether as providers, as professionals, pediatric and otolaryngology groups, whether we like it or not, this is what's happening. So, you know, this is Carl White mentioned, you know, several times. You know, this is exactly analogous to what happened with the newborn hearing screening back in early 90s, but a lot of professional groups are opposed to it, but they really had to get on board in a hurry once everything that came up, when it became a mandate. So this is the data from, you know, Utah, from Albert Park. Marissa Diner published this last year in Pediatrics. Well, I know what. Okay. Okay. All right. Sorry. As you excuse me. As you can see here, about 6% of babies who fail their hearing screen in Utah have actually tested positive for CMV, which is really consistent with the previous data from Pablo Sanchez's data from Dallas, Texas, as well as the Chimes data. So I think about 6% of the babies who fail, which is as opposed to 9.9% or less than 1% of babies, are sometimes maybe 2% of babies who fail. Okay, so thank you. So another really important finding from this study is really this is astounding. As you can see here, the shaded bars are the babies who. This is looking at the data in infants who completed diagnostic hearing evaluations within 90 days of those babies who failed their hearing screening. based on their CMV screening status. So when they're not screened for CMV, you can see almost 40% of the babies did not really complete the follow-up as recommended. Whereas if they had CMV screening done, it's close to 87, 90% of babies who went through CMV screening actually completed the follow-up, which is really, so I think Albert mentioned yesterday at the dinner, the Ontario province in Canada is looking at this, using CMV screening as a way to improve their hearing screening follow-ups. And this is the data from CHIME's data where we looked at, this is also published, I'm sorry, I don't have the reference here, Karen Fowler's paper in Pediatrics last year. So where we looked at the CMV status based on their hearing screening status. So of those babies who passed the hearing, who were referred on their hearing screening, almost, 2/3 of the babies had, sensorineural hearing loss related to congenital CMV infection. But another important piece here is, almost 40% of the babies who have CMV were infected with CMV and proven to have CMV-related hearing loss at their first follow-up visit, which is usually between 3 to 6 weeks of age, actually passed their hearing screens. So the considerable number of babies who pass their hearing screens still have confirmed hearing loss by 6 weeks of age. So we don't know exactly why this is. Is this the sensitivity issue of the hearing screening? Are the hearing screening occurring in that short period of time? It's possible, but it's probably not very likely. So this is another argument that at least I would make in terms of advocating for universal screening. So it's similar to what's been seen in Utah and Dallas. We also saw 7% of the babies who failed their hearing screens, among the failed hearing screen referred group have CMV compared to those, CMV negatives only 0.9%. So that's, I think I already talked about, that's why I think the universal hearing screening is the best strategy to identify most babies. I'm not saying we're there yet, there are still some barriers. So to be able to do that, I think, we need to identify how or what specimen that you would use and how to integrate into existing newborn screening programs. The specimens that have been looked at, urine and saliva or blood spots. Blood spots are very attractive because they're being collected from all babies for other screening purposes. So this is what we were asked to do by NIDCD when we started the CHIME study. So unfortunately, at least in our hands, the blood spot PCR didn't seem to do very well. The sensitivity is actually around 30%. So most of the babies who have confirmed congenital CMV infection had a negative blood spot PCR. There's still some hope. There's still some work that's ongoing by folks at CDC, and then there's a study that's going on in Minnesota to improve on this technology and improve the sensitivity of the assay. So then we moved on to testing saliva samples, because they're easier to get, easier to collect, and there's usually lots of virus, lots of viral DNA, sometimes to the level of 9 or 10 logs of virus in newborn saliva samples in babies who are infected. So this is not the actual paper. The data looking at the sensitivity of we published that in 2011 in New England Journal of Medicine, where we showed the saliva PCR assay, either the liquid saliva samples or the dried saliva samples would work very well. The sensitivity is greater than 97% and with a specificity of 99.9%. And then we subsequently looked at it, is actually saliva PCR identifies more babies with congenital CMV compared to the traditional culture-based assays. So I think, well, I already mentioned, in terms of screening, all babies with congenital CMV infection. The blood spot PCR is helpful if it's positive, but it's not very helpful most majority of the times because it's negative. It's falsely negative. So the clinical utility is not completely known. We did look at the blood spot PCR positivity and then hearing loss in our CHIME study, and we didn't see any relationship that doesn't seem to really help, at least in the small numbers we know right now. So the work is still ongoing. There are ongoing studies, as I mentioned, to improve the sensitivity of blood spot PCR. Urine and saliva we collected within the first 2 weeks are probably the best samples, okay? I know you may have heard Sutton's law. I think it's really Sutton, the bank robber, when they asked him, where do you rob banks? That's where the money is. That's where the money, in terms of looking for CMV, saliva or urine are where the virus is. It's kind of hard to design a screening program based on using a sample. There's hardly any virus or viral DNA. So both are appropriate samples, but obviously saliva collection is easier. And then PCR is comparable and maybe superior to culture-based method, and not many people are doing culture-based methods anyway these days. Sorry. Okay. And then also, I think Soren Gant in Vancouver has looked at the data in terms of looking at the cost effectiveness of screening, congenital CMV screening, and then estimated, I think, depending on what the test costs, estimated the amount of money it would cost to identify a baby with congenital CMV infection and the CMV-related hearing loss, and then this is the amount that you need to prevent one cochlear implantation. So, I think I know if we send the sample out to commercial labs right now for testing, the charge is anywhere from $150 to $300. But that's not how newborn screening is done. Newborn screening is a mass screening. That people are charged per test. It's just the state gets allocated certain money for the screening purposes, and then they do it. So it's not realistic to think that you would pay $300. That would never actually happen. The cost effectiveness from Soren Gant, I think, what he showed was newborn CMV screening was cost effective under a wide range of assumptions, even assuming that no effect from antiviral therapy. Screening is essentially cost neutral when costs related to loss of productivity are included. And the substantial savings due to either identification and directed care for late onset hearing loss. So when modestly effective antiviral treatment is assumed, screening results in cost savings, and universal screening incurs greater direct cost but greater net savings than targeted screening under all scenarios. So I think we have most of the components that are in place. So I think when you look at the guidelines, when you look at the Uniform Panel on Newborn Screening, the RUS panel guidelines, they look at certain criteria, whether they're met or not. So one is do we know the natural history, case definition, incidence, and prevalence? So yes. Do we have a screening test or a test algorithm for the condition of sufficient analytic validity? I think I would say yes. Has the clinical validity of screening test in combination with diagnostic test has been determined? I would say yes. Has the clinical utility of screening test benefits versus harms?
Red, kitchen dish room, number 2. Red, kitchen dish room, number 2. Red, kitchen dish room, number 2.
Okay. I hope it's nothing. I'm not very useful. Anyway. So with the clinical utility of screening test, the benefits or harms, I think, I would say yes, and some people would say we still don't know. I know we always talk about, causing, more harm are causing maternal anxiety and then interfering with the mother-to-child bonding, those kinds of things. And at least in our CHIME study and then some of the other surveys people have done, we haven't seen that. Seen that to be an issue. Is there evidence that screening leads to improved outcomes? I think we don't really have a solid data from population-based studies, but most of the studies are hospital-based studies. But I think I would argue that we do have direct evidence, but I think some of the experts in the field are still not convinced. And we know the cost effectiveness, and we know how cost effective screening is, the diagnosis and treatment of babies with congenital CMV infection is. So I think we meet most of the criteria. I think I think what Sarah Dutray and some of the people at the National CMV Foundation and NCHAM are trying to put together a proposal to submit to the RUS panel soon. We will see how that goes, and at least even if it doesn't meet the criteria for the recommendation, at least we'll know exactly what they're thinking and what needs to be, what are the gaps that needs to be filled. I don't think I have really that much time, but I just want to go over a few slides of the CMV-associated hearing loss. CMV-associated hearing loss can be present at birth in about 60%, but can develop it later, and usually within the first 4 to 6 years of age. And it could be unilateral or bilateral. There's varying severity ranging from mild high-frequency unilateral loss to profound bilateral loss. There's no typical audiogram. I mean, if you look at 10 different audiograms, 10 different kids, their audiograms, they're all different. There's nothing consistent, consistently typical audiogram that you would see with some of the genetic hearing loss causes. And then other thing is, lots of times, even though the hearing loss is not severe to profound or moderate to severe in the beginning, and once they start having hearing loss, or even they have a hearing loss at birth, they continue to progress and worsen over time. So you can see, I think almost half of the babies with asymptomatic infection had moderate to severe, or moderate to profound hearing loss. And the vast majority of symptomatic babies have severe to profound loss. This is based on the CHIMES data. And then overall prevalence of CMV-associated hearing loss in the CHIMES data at birth is about 8%, and at 4 years of age is 12%. One of the things I just want to point out, in terms of the newborn hearing screening refers and CMV, I mentioned to you there's a 7% of the babies who refer on CMV, refer on hearing were positive for CMV. But if you look at the numbers in NICU, they're really almost a quarter of the babies in the NICU who referred on hearing actually end up having CMV. Although the numbers, vast majority of the babies we screened in CHIMES, 98% are from well baby nurseries. So the number may not be that high. So I'll skip some of these. I think one thing I want to point out here, this is the data from longitudinal studies at EAB over the past, it was done in the 80s and 90s. So one thing I want to point out, the median age of delayed onset hearing loss is 44 months in asymptomatics. That needs to be kept in mind when you design following treatment trials. So because right now the treatment trials, the 6 weeks versus 6 months trial are only followed babies for 24 months. So there are a lot of babies who could develop hearing loss later on just based on the natural history. I think I was talking to Albert and Hillary last night, and they have some data to show a lot of babies who were treated actually have developed hearing loss between 2 and 4 years of age. So that's consistent with with these numbers here. I just want to point out, even in Brazil, where 96% of women and pregnant women are CMV seropositive, about 12% of the babies with CMV have hearing loss. So we don't really know a whole lot of hearing loss pathogenesis. Unfortunately, I don't think I have a whole lot of time to talk about it. I think there are exciting data. There are exciting data in animal models. There's I see maybe 2 or 3 groups mainly working on. One is Albert Park is working on a mouse model with intracerebral inoculation. Bill Britt in our group is working on a newborn mouse model where intraperitoneally inoculated CMV. And then there's a Japanese group who's working on it. So hopefully we'll know more. But it seems the consensus is, you can detect virus in the cochlea, mostly in the supporting structures, but there seems to be a lot of inflammation. So the inflammation seems to be the one that's driving hearing loss in those settings. So I'm sorry, I'm going to skip all of these slides because I want to have some time to. This is actually I was going to show Albert's data about if you knock out natural killer studies, natural killer cells in the mouse model, then you have much higher prevalence and much worse hearing. So the mechanisms of CMV-associated hearing loss have not been well defined, not been well studied. Temporal bone specimens, been looked at, but it's obviously going to be very limited. Animal model systems can offer potential to understand disease mechanisms, provide rational interventional strategies. And I think both virus persistence and inflammation represent potential mechanisms of damage in the early stages of development. And then the other thing we don't really know is the role of host viral genetic factors. We did some pilot study a while back, about maybe more than 10 years ago. We looked for most common mutations at the connexin 26 and connexin 31 in our population with congenital CMV, and we didn't see any. But our population is mostly predominantly African American population. The most common connexin 26 mutation, 35 del G, is not really found in that racial group. But we did find more some mutations we don't really know, a significantly higher frequency of some of the changes, variants in the connexin genes in the CMV infected children, but we don't really know the significance of that. Okay, so just to recap, congenital CMV infections are common throughout the world, leading cause of hearing loss and other developmental disabilities. Symptomatic infection is with higher rate of sequelae, but not all symptomatic infections have the same risk. Predictors of outcome in asymptomatic congenital CMV infection are not known. And the saliva real-time PCR is sensitive and specific for both screening and diagnosis of congenital CMV infection. Antiviral therapy has been shown to improve and protect hearing in children with symptomatic infection. There's certainly other gaps that I'm not listing here, but one of the several things that we know very little about. We don't have a really good clue of what immune correlates to protection, both in seropositive and seronegative women. One of the huge problems with vaccine development of CMV is majority of the babies with congenital CMV infection are born to women who were previously immune or have CMV seroimmunity prior to pregnancy. So that's really as a paradigm shift, and that's really, we don't really know why women who are already seroimmune can still have babies, can still transmit the virus to their babies. So some of these I actually mentioned. The other thing is, what's the optimal duration of antiviral therapy? 6 months, 4 months. Some Israeli groups have been treating for 1 to 2 years. We don't know. We have no idea. Do we know whether babies with asymptomatic infection would benefit from antiviral therapy? We don't know. The other thing is we know there's very little awareness. I think we need to find out. We need to develop strategies to improve awareness. Okay, and just a shameless plug. We're hosting the CMV 2019 conference in Birmingham, so we're hoping for good attendance. Thank you so much, and I'm sorry there's not much time left for questions, but I'll be happy. I'll hang around and.
Any questions?
Thank you very much. For all this study, the confirmation was done with a high IgM level, or for all the CMV infection, how is it confirmed? by elevation of IgM.
Which one? I mean, mothers, you mean, or babies?
Babies?
Baby serology is not very useful. IgM, I guess if it's positive, it's helpful. But, we don't use any kind of serologic assays because of the passive transfer of maternal antibodies, although IgM is not transferred, but it's not very good. So we use virologic tests, either detection of the virus or viral antigens or viral DNA.
Thanks.
Other questions? I'm glad I didn't know that when I was pregnant, that if you were already immune, that you guys would have given me one more thing to worry about. Any other questions? Oh, making me run.
Thank you so much for that presentation. One of the issues we have with our parents a lot is the issues of the mouse models that, talk about carcinogenesis, teratogenesis, and aspermatogenesis, and that's obviously really scary when you're talking about newborn babies. Can you talk about what's being done to collect long-term safety data to address these issues?
Not sure there's any systematically collected safety data. People who take care of immunocompromised patients don't really think it's an issue, but I don't know what their follow-ups are. I don't know. I guess you get to balance the risk-benefit in those situations. Ganciclovir risk of what is potential side effects of ganciclovir is probably not as big or as heavy, as large as actually not treating the disease. But in babies, that's an issue with asymptomatic babies, right? And babies who are completely fine, but only 10 to 15% of them will have hearing loss. So how do you explain that? I don't know. I think CASG group and David Kimberlin and them have tried to go back to the previous trial where 6 weeks of IV ganciclovir trial and bring some of those children back and do some evaluations, including endocrine evaluations for these potential side effects. But they haven't. They've done it on few children, but not very many. So they weren't very successful in getting those children back for doing those kinds of an evaluation. So that's still a concern. I think unfortunately the consent form has to say all of those things and then be discussed with the parents.
Anyone else? No? Well, join me in thanking Dr. Boppana